the most important thing is that all of us in our individual roles and within our organisations focus our attention and our resources on the things that really matter to patients. And it's defining outcomes in terms of what matters to individuals, not just at particular points in time, as Richard was inferring, but across their whole experience of care.
At any given time, we've had up to 200 people forming part of a collective panel that can be contacted around decision making relating to stroke. And then clearly coming together in focus groups together with staff around an experience-based design model to look at the way that we change and improve services. So there's some examples of ways that we've worked. And typically in other services too, the experience-based design methodology is something that we're finding increasingly helpful in terms of a way of improving care around the stuff that matters to staff and matters equally to patients and families that are using those services.
All we really want is to move away from cliches and formality and alienation, and to have a little bit of what we all think we owe each other anyway, just as sort of human beings. And that can, I think, fairly cheaply, fairly easily, fairly immediately be incorporated into healthcare provision. And the immediate sort of route into that would be, I think, at the education stage.
I'd like to measure more morbidity data and comorbidity data. You know, we had a lot of references, even in cardiac issues. It's not just about whether people survive. It's about what the quality of their life is, you know, after that intervention.
Second message is the importance of treating people as individuals with real lives, you know, with a kind of range of health and social care needs, and not just as patients with a set of clinical symptoms. That sounds obvious, but time and time again we do see, don't we, and we'll all be aware of it, times when actually the conversation becomes about the symptoms and not about the person. And it's about recognising that actually patients with conditions are experts in their own bodies, they're experts in what it feels like to live with that condition. And it's about understanding and drawing on that expertise so that actually the expertise of the patient and the expertise of the doctor and the nurse is combined to create a true partnership.
I think importantly, an opportunity to really involve service users as inspirational role models. So an example again with some stroke, as stroke peer supporters, visiting patients very early on in their journey and signposting them to information that they've received, accounting for their experiences, looking at the complexity of living with stroke in relation to everything else that's going on for them at the time, and being able to share useful links in the community that exists.
One of the things I picked up earlier on was this quote about the aggregation of marginal gains. I think, you know, it's a lovely phrase, but basically means that each episode is measured, you know, in terms of the quality of the recipient, and that each episode that goes well contributes to health, and each little episode that goes wrong contributes to disease and illness.
There are still people out there who say, actually it's clinical outcomes that matter and patient experience is the fluffy stuff. We know damn well that if you're rude to somebody, they may be less likely to go to their follow-up appointment. They may be less likely to take their medication. I think we need to make that link between patient experience and clinical outcomes more explicit.
And lots of times people said things to me like, yeah, it's very interesting, but you know, we've got to get this hand hygiene business in and just don't have time in our packed curriculum. And it just strikes me as implausible that in the many years that people sit in classrooms and learn, you know, the aspects of anatomy and hand washing and all the rest of it, there isn't half an hour set aside to just talk about this kind of stuff.